All right, so let's go ahead and start. Let me close the door here. All right, so as I mentioned in the lecture, I think just a few preliminary thoughts. One is, when you're reading a study to critically appraise it, you shouldn't be thinking that you should read this paper like a novel. Like start reading page by page, and then that is not the way to read a paper. You will waste so much time. The strategy is to come up with the questions. Those questions that each type of study that we're going through, we have a set of questions. You use those questions that are in your mind, and they're active in your mind. I need the answer to these questions, and you can sort them in a certain order, whatever order you want, but you need to learn those questions. What you do is the other aspect is you learn the anatomy of a paper. I have this question, oh, I know where I will find the answer, and you page to that place and find the answer. Once you find the answer, you check it off and go to the next question. So that's really a much more efficient way to go about it, okay? So the other thing is, when you are doing critical appraisal, you always start with a patient, right? So you have a scenario, and it's really important that you frame the question in the framework of what? What's our framework for the question? PICO or PICO, okay? PICO. And PICO emerges from the patient. Those words, okay, that you put on the paper for PICO form the basis of the literature search, okay? And once you've searched and you find the paper, now there's a PICO that emerges from the paper, and you want to match that with the PICO from your patient, okay? So we're going to have a scenario here, and what I want you to do is, from the scenario, come up with PICO. Now, PICO for a diagnostic test validation study is a bit different from the usual PICO, okay? So someone read this and see if we can come up with a population, and instead of saying exposure and outcome, let's say test and gold standard, okay? In this population, does this test accurately diagnose this disease that's being measured by the gold standard? Okay, so that's how we'll set PICO up for this. So someone go ahead and read this quick scenario and see if you can frame the scenario into PICO. Go ahead.
Okay, so you're an assistant to the director of a general hospital who tasks you with assessing the accuracy of 64 multi-detector raw CT angiography in the diagnosis of coronary heart disease, CHD. Assuming the negative predictive value for the device is sufficiently high, the scan could be used in some patients presenting with chest pain to rule out CHD without needing to send them to the more invasive gold standard test, which is coronary angiography. You do a literature search and find the following article and the citation. You need to critically appraise the article and report back to the hospital director.
Okay, so let's frame the question. What is the population in which you would use this test?
So population is people, adults suspecting to have coronary heart disease.
Okay. And who do you suspect heart disease in? People with chest pain. So think of this set of symptoms that lead a physician, or symptoms or signs or whatever set of clinical findings lead you to do this test. So in patients with chest pain, suspected of heart disease, okay, does what? Does CT angiography accurately diagnose coronary artery disease as diagnosed by coronary angiogram? Okay, so that now sets, that's how you frame this kind of question in that framework, okay? Now, when you are doing this, let's say, here's how it goes. So the population is chest pain, let's just say, and the test, we'll just call it test, is CT angiography, and the gold standard is CAD angiography, okay? A coronary angiography, all right? Now, you get these words up on the page, right? And this could go for whether this is a randomized trial, you have your population, your intervention, comparison group, and outcome. You have words up there. Now you want to do the search. How do you choose which words go in your search? How do you do that? I mean, here's chest pain. I mean, do you just put in chest pain, CT angiography, coronary artery disease, coronary angiography? Do you put all those words in? How do you choose which words to put in? I'll give you a way. The easiest way I know how is to pretend that I'm the author of the paper that I want to find. And I say to myself, of these words, which words have to be in the title? You could not write the paper without that word in the title. So, could you write the title without the word chest in it? And chest pain? Could you? Could you find a paper on this topic without the word chest pain in it?
No.
Well, let's pretend. If I were an author, I might say CT angiography and the diagnosis of CAD. You don't have to have that word. Do you see what I mean? Like, exit out. Say, I don't have to have that word. What words up here has to be in there? CT. You couldn't write it without the word CT, computed tomography. You could not do it. How about CAD? Okay, maybe. Yeah, CAD is kind of what you're diagnosing. So it would be unlikely that you wouldn't have coronary artery disease somewhere in the title and CT. Now what about coronary angiogram? Does it have to be in there?
Yes.
You're saying no, you're saying yes. You're saying no. Give me a title that does not have angiogram in it. Yeah. You don't, like, it wouldn't have to be in there. The gold standard wouldn't have to be in the title. You can imagine a title without it, but I cannot imagine a title without CT in it, and I think probably CAD. So let's just say we put in here computed tomography, right? What would you actually type into PubMed? Computed tomography and coronary artery disease. Okay. Now, and do you want another and? Or just, let's try this, okay? So, if you type this in, how many papers do you think you would actually get? Would you get a lot of papers? Do you think you would get papers that don't relate to your topic? Well, one thing you have to understand, when you are searching like this, what is it actually searching? It's searching all the text in the paper. So do you think there are papers that might have CT in them and might have coronary artery disease in them that has nothing to do with this topic? Somewhere buried in the discussion it says something about CT and something, but it has nothing to do with the topic of ours. Yes. So what is a strategy to take this and move it to what you want? Yeah, so you can filter it, but there's a specific filter, and that is title. So what I would do, I would say computed, and I would put title. Okay? I'm going to demand that computed be in the title, because I can't imagine a paper about my topic without the word computed in it, and tomography. So I would say computed and tomography. So I'd put and tomography in the title, right? And I'd put that, and so computed in the title and tomography in the title and coronary in the title. You could put artery in the title and disease in the title, but let's just say if it's coronary artery disease, you'll pick it up if it's coronary. So, and coronary in the title. Now, do you think, how many papers would there be? There'd be some with the word computed and tomography and coronary in the title, and how many of those, what percent of those papers do you think would relate to what you want? Very high percentage. That's the key. That is the way that you get rid of those frustrating searches where you have 3,000 papers and none of them seem to relate. Think what word has to be in the title, and then you search on those terms and force them to be in the title. See the strategy? Very simple, but it's very helpful strategy. Okay? All right, so you do that, and you find this one. Now let's just check. I didn't check, but would this paper be picked up by our, would it be computed? Now it's tomographic. Tomography would not have picked it up. You see, so you would have to be careful. You have to think of the synonyms for these words and say tomography or tomographic, or just tomograph star. And that would pick up tomographic, tomography, tomograph star. That's like a wild card letter. Okay, so actually the way we did it would not have picked this one up because of tomographic. Okay, so it would be computed, tomographic, and coronary. We get it. Okay, we would find this paper. All right? So now, we find this paper, and now what did we say? We had PICO from our scenario, we searched, and now we need to, the first thing you need to do when you look at a paper is to get PICO from the paper. And what's the first stop? Where do you go first to find PICO?
Methodology.
Well, before the methodology. Even before the objectives. Even before the abstract. The title. Okay, so start with the title. Okay. Can you see from this title PICO? So from the title, most of the time you get most of PICO. Sometimes a good title will have all of PICO in it. What do you think? What is PICO based on this title? It's a long title, complicated title. But can we sort it out? Can we sort out what our PICO is? What's that?
Patients without colorectal disease.
Okay, what's that?
That's the population.
The population. Now, I'll tell you a quick thing. There are two words, in and among. If you see the word in, you know that's the population. So let me ask you this. Is diabetes an exposure or an outcome?
Diabetes.
Diabetes, is it an outcome or an exposure? Can it be a population? Sure. Diabetes, so just because you see a disease doesn't mean it's the outcome. It could be the population. So one way you can try is look for the word in or among in the title. If it says in diabetics, it means that's the population. If diabetes is the population, can it be the exposure or the outcome? It means that everybody in this paper has diabetes, right? If it says in that, then diabetes is not going to be the exposure or the outcome. Okay, does that make sense? So the population you can see in individuals without known coronary artery disease. The implication here is that they have chest pain, right? They don't say in patients. in individuals with chest pain without known coronary artery disease, because then that would have to go to 5 lines, and they didn't want to make 5 lines, right? But, so we know that the population is people without known coronary artery disease. And then what's the exposure or the test? Do we have the test and the, okay, CT. And what's the outcome?
Evaluation.
Positive or?
What's the disease that they're testing for? Coronary artery disease. Do they show the gold standard here? The gold standard here in the title? No, it's not here. Then, if you don't get PICO from the title fully, then where's the next stop?
We go to the objective.
Yeah, the abstract, where the objectives and abstract are, and you can see. Can you see what's the gold standard? Do they say?
Study to evaluate the diagnostic accuracy of the electrocardiography, gated 64 multi-detector row CT angiography in individual without non-coronary artery disease.
Yeah, but what's the gold standard? I'd like to know.
The methods.
Yeah, in the methods, it says.
Yeah, or clinically referred for invasive coronary angiography.
Yeah.
Implying that the invasive coronary angiography is the reference point.
Right, right, exactly. The ICAs were evaluated for coronary stenosis based on the quantitative coronary angiography. So the stenosis is the outcome and is being measured by angiography, regular, like invasive angiography, and then the CT scan angiography is the new test. Now, what is the purpose of this test? What are they actually wanting to do? Because here's the thing. You have to say, what's the clinical scenario in which this test would be used? And why would they be using it? And how would they use this test?
They aim
The
to
accuracy of the test.
Actually, he was first. Let me get, yeah.
they aim to find a less invasive way to become close to the gold standard, or might stratify patients to go to coronary angio based on the calcium scores of the CT angio.
Okay, Ahsan, that's it. But why would they want that? Why would they want a less invasive test?
To avoid side effects, easier access, not
Okay,
available.
it's cheaper. So how would they actually use it? They send someone who has chest pain, they think may have coronary artery disease, they send them to this CT. If it's positive, what do? Angiography. So do they need to diagnose do they need to diagnose coronary artery disease for sure on the CT? It's being kind of used as a screening test, but it's among symptomatic people, right? They're doing a screen. If it's positive, they don't have to diagnose it here because they're going to go on to the more specific test. But if it's negative, what do they want to do? They want to rule out. So which test do they really want to trust? The positive test or the negative test? They want to trust the negative test. They want to trust the negative test. So now, would that be helpful if it could do that? Sure, because you don't have to stay overnight, and if it's negative, you go home and you're fine if you can trust the negative test, right? So when you're doing this kind of study, you have to think through how are they going to use it, how would I use it, and what's the purpose? If it's positive, if it's negative, how would it actually work, and why? Why are we doing this? Okay? So that's how we would do it. So the first step is to assess the population. Okay? I want to know, well, before we go on, do you think, knowing this now, does this seem to match our question? The PICO from the paper matches our PICO from the scenario, right? Good. So now, the first step is to get PICO from the paper. Fine, done. Then the next question is who got into this paper? And do you remember what I said in the lecture? It's critical that you understand the population, because there are published studies that make the wrong population. And if it's the wrong population, it's not going to, the sensitivity and specificity could be biased. So how do you think a diagnostic test validation study is organized in the methods? What do you think comes first? Do you think, what do you think comes first? Is it the gold standard or the population? Population comes first, and then what do you think comes next? The test, and then what do you think comes next? The gold standard, and then the statistical analysis. In a randomized trial, how do you think the methods are organized? What comes first? Population, then the intervention in comparison, and then the outcome. Did I hear that before? Population, intervention, comparison, outcome. It's PICO. In a cohort study, what comes first? Population, exposure assessment and clinical measurements, and then outcome and follow-up. PICO. Okay, so that's the thing, because now I want to know who got in the study. Where am I going to go looking? First stop in the methods, first place in the methods. And look, is it there? Is it there? It's there. Oh, okay, so now I know who got in, so now I'm very curious. I need to know who got in here, and you tell me what you think about this population. Just screen it here and say who got in here.
Other subjects of just years?
Okay, they were over 18 years.
Were already referred for
Chest pain, typical and atypical.
Typical and atypical chest pain.
Referred for non-emergent ICA.
Yes, and they were already being referred to ICA. Okay?
And it's from 19
Without allergy or dysfunction.
Okay. Okay, good. So they didn't want people with renal impairment and giving them a dye load. Fine, an extra dye load. Okay, so here's the thing.
It's from 16th center in US.
Very good. Another thing is, where was this done? If it's done in a multi-center study, that gives it more weight. If it's done in only one place, it's less weight, okay, less importance. This is a multi-center study, okay, and yeah, so where was the study done? In the US, 16 different centers. And then what are the inclusion and exclusion criteria? We already talked about that, right? So now, just summarize in one sentence who got into the study. Symptomatic people with what symptoms? Chest pain of any kind, who were being already referred for, who had the concern of coronary artery disease enough that they were going to go to cath. Fine? Now, notice here that it's non-emergent cath. Do you think that there's spectrum bias here? You see, they didn't include the sickest people, the emergency cases. So do you think there's spectrum bias because they excluded those emergency cases, the severe cases?
It's not applicable to, because you have very short time to treat the emergency cases with cholangitis, so you can't
Yeah.
subject them to another test. My lady got some-
Okay, ahsant, that's it. So the thing is, don't think what's the full spectrum of heart disease. No, you say what's the full spectrum of people who would get this test. So you wouldn't take an emergency case to say you know, they're doing chest compressions and they have tombstone ST elevations and the guy's almost in VTAC and say, let's go get the CT and see what that says. No, you're not going to do that. So that's appropriate. That's the level at which you want to be asking. Are the people who got in the study people who you would send to this test? Do you see? You've got to ask that question when you're doing an assessment of a critical appraisal of this kind of study. Now, there's another word. Did they get consecutive people? Because I always like to see consecutive patients. So I'm scanning to see, did they get consecutive patients? And I can't remember if they did. Consecutive means they didn't skip anybody. Whoever was referred got into the study, or was approached to see if they would get in the study. They didn't cherry pick people.
They did exclude.
Yeah.
They exclude the patient with renal impairment, their own.
Yeah, that's
Exclusion.
exclusion. Yeah, there were some people they excluded. They didn't want to give a double dye load, a CT scan dye and an angiogram dye. But that's not what I'm talking about.
The selection bias, like selection bias.
Yeah, they don't say it was consecutive, but I like to see it consecutive.
They're saying individuals who are eligible for participation, so they have to sign up for it, or
What I mean is, when I say consecutive patients, it means every person who came was offered to be in the study. They didn't look at them and say, well, this one's pretty sick, I'm going to skip that one, or do any sort of playing around. They took consecutive patients.
The patient study subjects were screened and enrolled by the site's research coordinator. They made code inclusion, so they don't say that.
Yeah,
They were consecutive.
it's like elective.
yeah,
So it was the subject to the researcher.
yeah. Okay, so do you think this population has a potential for selection bias, therefore? Selection bias.
You're not taking everybody.
Well, we don't know that. I think that in terms of the population that they're describing, do you think the population they're describing is biased? No, it's the people who would ordinarily get it. I like to see consecutive, but if they don't say it, you kind of assume that they're taking it. Okay, so then you say, is the severity of disease in the patients in this study different from the severity of disease of the patients I will be seeing in my ER? Okay, so they did it right. They did it right.
But they didn't specify which patients were referred for angio. But this was a clinical decision based on
Yeah.
which criteria they referred patient for angio.
Right. So you're hoping that the ER physicians or the internists know what they're doing. This is a clinical setting, and it's going to be used in a clinical setting, right? It's going to be used in a clinical setting.
Where are they referred from? I mean, you have people being referred from polyclinics, from medical OPDs, from cardiology OPDs.
Yeah, it could be,
Especially if they're atypical chest and one they referred to for coronary angio, for example. If you're deeming them to be
Right.
atypical chest, for example.
right. Well, it's just saying that anybody, wherever they're being referred from, either the ER or the internist clinic or from wherever, they're being referred. So they've met some clinical standard of needing an ICA. Now they're not saying what the criteria are, other than doctors are referring them. Doctors are referring them. So you have to say, well, this is sort of the clinical practice, right? In the setting in which a physician would say, I want to refer somebody. Now, that may be different for different physicians, but, so you're good to think about that aspect.
They actually touch on this topic in the results, the first paragraph.
Yeah,
Of the patient study cohort, 147 patients underwent stress testing by a range of different tests, treadmill, exercise, echo, etc., pharmacological echo. And then the remainder of the test cohort was referred on the basis of symptoms and or testing not the part of the primary study. They're
Yeah.
trying, I mean, they didn't get into the details.
but they give some description of, and you look at that and say, yeah, this sounds like a typical clinical practice. You know, they don't seem to be deviating from that. Okay, so that's the population. That's the first stop when you're doing the critical appraisal part. First thing is do PICO, then assess the population. Is there spectrum bias? Then let's go to the gold standard. Do you see how quickly that would take you to do? It wouldn't take long to assess PICO. It doesn't take long to find out who's in there and whether they're appropriate. The next stop is the gold standard. So we said that these papers usually in the methods talk about the population, then the test, then the gold standard. So I would look and see what these are. So patients, CCTA, that's your CT part, which we'll come back to. And then on this page, 1726, do you see the section? Where do you go there? And let's ask some questions about the coronary angiography. First, is the test compared to a gold standard? We already answered that question, yes. What is the gold standard? Do you trust that test? you think is a good gold standard or a lousy gold standard? It's the gold standard. It's what we use clinically. We have nothing better other than autopsy, and then it's too late, right? All right. So then say, how is this gold standard done? Is it done over time? Is it done at one time? So it's a one-time thing, not done over time, fine. And then, what's the nature of it? In other words, how do they determine whether someone has disease or do not have disease?
That's visualization.
Okay, they visualize, and what do they actually measure? The stenosis, right? And then how do they report the stenosis? Let's say it's this, right, divided by this, right? It's a 1 minus that, actually. So it's the percentage of narrowing there, right? And so what does it range from? It ranges from 0% to 100%. So it's a continuous measure, right? Then we're going to need to ask, well, what's the cutoff that they use for the gold standard to say there is or there is not narrowing or stenosis? Or not narrowing, to say whether there is or is not coronary artery disease.
More than 70, I think. 70.
That's a clinical standard is usually 70% or sometimes 50%, right? So let's look for that. Can anybody find anywhere where it talks about what is the cutoff for disease in the gold standard?
15 was 1.5, more than 50, more than 70.
Yeah, so what page was that?
1727.
Yeah, on 1727, there's a, in 1726, I think it talks about the cutoffs for the test, right? But here, on 1727, right around here, okay, it says, all analyses and all vessels were included. Analyses were performed separately for two distinct conditions, greater than 50 and greater than 70, that defined obstructive coronary artery stenosis. So on the coronary angiography, they actually have two gold standards now. They have a gold standard at the 50% cutoff and a gold standard at the 70. They're doing it both ways. Fine? So now we know something about the gold standard, and we want to look, while we're looking about that, maybe go back to the previous page, what was the comparison blinded? Did the people doing the coronary angiography know the result of the CT? Does it say?
Blind, yes.
Where does it say?
The degree of coronary artery stenosis identified by CCTA assigned based upon consequence of 2 of the 3 blinded CCTA readers.
Okay.
Identified by the coronary artery.
And that's on
And the last paragraph,
1726, right here. All ICA images were interpreted by independent ICA reader, blinded to all patient characteristics in CA. Okay? Now, was it the other way around as well? How about the CT? Do you see anything saying that when they read the CT, they were blinded to the ICA results?
Yes, also here.
Yes.
Same page, left paragraph. Yeah?
CCTA images were interpreted separately by 3 readers, blinded to all patient
Yeah.
characteristics of ICA.
So do you see how you have your list of questions and you're just looking for the answer? As soon as you see the answer, you stop reading. You don't have to read MJB, DD, and JKM blinded to it. Like, you just say, there's the answer, and I'll move on to the next question. And in fact, we just answered a question about the CT while we were thinking about the ICA. You keep bumping into answers to other questions when you're scanning. You're scanning for the answers, you're not reading whole paragraphs. Okay, then what's our next question here? So anything else about the gold standard? Was it performed on everybody? And I forgot to mention in the lecture, I think it was up there, but I didn't say, if the gold standard is not done on everybody, there's a potential for something called verification bias. So you want to check. So checking the abstract, because it doesn't really say it explicitly in the text, but it does in the abstract. So just look in the methods of the abstract, or the results.
Underwent both
Yeah.
CCTA and ICA.
All patients underwent both. Okay, so now that one it took me some time to find it somewhere, but I mean, there really would have been no reason not to, right? There's no ethical reason not to do the coronary angiography. They were all being referred to that. So, so what's the risk of verification bias? There's no risk of verification bias. So it seems like our spectrum bias is minimal. Our verification bias is absent. Okay? All right. Then let's look at the test. How is the test? Let's see here, yeah. Okay. How is the test interpreted? What's considered a positive and negative test? So remember, it's population. Then let's go back to test, which is before gold standard. So where, well, it says patients and then CCTA image acquisition. It tells you about the CT scan itself, how many beats per minute, and IV administration of metoprolol if the heart rate was too fast, fine. And then, yeah, so look under CCTA interpretation. Ah, there's the blinding.
Artery stenosis identified was signed based upon consensus of more than 2 of the 3 blind cadavers, identifying narrowing of the coronary artery lumen at a threshold of 50 or 70.
Where are you?
Last paragraph before ICA image acquisition.
Yeah, and then before that it says they were going to look at it in the following manner. Look just in the paragraph right above it. It says no stenosis, 1 to 29%, 30 to 49, 50 to 70, 70 to 99, and 100% stenosis. Okay, so they're going to look at a bunch of different cutoffs. All right. So let me see here. Does this? No. Okay. Let's see what else here. Was the person performing the test procedure blinded from the results of the gold standard?
Yes.
We already answered that question. What cut points were assessed for the test? We already answered that one. Are the two tests independent of each other? Is the test somehow incorporated into the gold standard? No. So that you just say, oh, done. All right. Now let's look at the results. And we're going to focus on the 70% cutoff. They did it at the 50 and the 70, but we're going to look at this here. Okay? So let's look at the questions. What is the prevalence? Before we get here, before we start looking at the results, I want to know what the prevalence is. Why? Why do I want to know what the prevalence is in this paper? Well, yes, because that's the pretest probability, right? Our pretest probability. So where do you think you go to get that number, the pretest probability? Well, you might, actually, this would be a great place to put it. Just say pretest probability. They didn't put it in the table, so where might you find it? In the text. So where in the text do you think you would find it? In the results. So let's go looking in the results. And where might you find it? So the results section, patient characteristics comes first. And then do you find it patient-based evaluation? Do you think it may be in there? No, but don't look at that. I want to know what's the pretest probability or the prevalence of disease at the 50% cutoff and at the 70% cutoff. What's that? I don't think they have it there. Those are just the risk factors. Look under patient-based evaluation right here.
There were 57, 32 subjects.
Yes, that's it.
Found to have more than 50 or 70% stenosis respectively.
By
By
QCA. By the gold standard, what percent had stenosis more than 50%? 24.8. And what percent had more than 70%? 13.9. Now, why do you think the prevalence at the 50% cutoff is higher than the prevalence at the 70% cutoff?
Lower threshold.
Yeah, it's a higher threshold for the 70%. There are going to be fewer people up there and more people above 50. So that makes sense. So it was about 25% for the 50% cutoff and about 14% for the 70% cutoff. That's an important number to remember and to find in the paper. Okay. Now let's go here. Let's see. So here is the sensitivity, specificity, and the positive predictive value. Let's just look at this one here, the more than 70. What do you think about these numbers? Do you think they're high, low, and what numbers are you actually going to be looking at here?
Predictive value.
Okay, the negative predictive value is an important number here, right? So it's 99%. And so what, do we care more about the specificity or the sensitivity? Well, the sensitivity and the negative predictive value are important, right? So this is high. Is this high? Yes. And is the pretest probability fairly low?
Yeah, 13.
Yeah, 13. So you have a low pretest probability and a high sensitivity, relatively high, which those two together give you a high negative predictive value, right? Do you see? So okay, fine. That's good. What do you think about the positive predictive value? Is that a problem? Are you bothered that 50%?
No, they will go for anything.
They're going to go for angiogram anyway, right?
Want to rule out.
Yeah, the point here is I want to make sure the negative predictive value is high. Okay, so that seems pretty good. Now, let's look at the confidence intervals, though. And fortunately, they show us the confidence intervals. There are a lot of papers that don't show the confidence interval, and I know how to calculate it, and oftentimes it's really wide. Okay, so this here is a problem. What does the confidence interval mean, actually?
95% chance. If you repeat the test 100 times, 95 times a day.
You know what? The biostatisticians would love you. He said if you repeat the study 100 times, the result would lie between these two numbers 95% of the time, which is correct. The problem is, does that make a lot of sense to you? Like if I repeat it 100 times and then I'm lost. I'm repeating the test 100 times in my mind and I get lost. God bless the biostatisticians, by the way. We need biostatisticians, but that's a different, that's if you want to do biostatistics. If you want to apply this to the way you think about research, it's this. Out there are lots of people with chest pain. And we're going to do a study to see if this test is accurate in the diagnosis of heart disease. Can we include everybody with chest pain out in Kuwait into this study? No, we have to take a sample. So we take a sample of people and we put them in our study over here. Here's our study, and I've got a sample. And what happens is, what is it? It's the sensitivity is 94%, and the confidence interval goes from 79 to 99. Where does this one come from? Where does the 94 come from? From the study. What is that talking about? It's talking about the people out in the population. It says, here's how you interpret this confidence interval. Say, From the study, I see that the sensitivity is 94%. Can I say that out there it's 94% exactly? Could it be 95? Could it be 93? Could it be 97? Could it be 89? So what this is saying is I am 95% confident. So when you start thinking about confidence intervals, say, I'm 95% confident of something. What's that something? What am I 95% confident about? That the true sensitivity out in the population is somewhere between here and here. Now does that make sense? You see, this one is, these are candidates for the truth. This is what the study says, but this is what the truth could be based on this study. Now, this one is still the best, this is the best estimate, but the truth could be here or it could be here. So how do you use this? You say, what would I do if this were true? What would I do if this were true? Would I trust? I would say that's a very high sensitivity. What would I do if this were true? Say that's a bad sensitivity. So if the inference from the lower end is different from the inference at the upper end, then you have wide confidence intervals. You have less confidence if the inference and what you would do with the patient or what you would say to the patient is the same or similar at the upper end and at the lower end, then you have more confidence. Okay? That's how you use these confidence intervals. And if we have time at the end, I can go through some more examples because it's really, really helpful. Really, really helpful. Okay? Now, let's see if we can get through this, and then I'll come back to the confidence interval. So, would you consider these confidence intervals to be narrow or wide? This one I would consider wide. But now, look at the negative predictive value. Is this narrow or wide? Well, it's kind of narrow because this is, I would do it. I would say very, very good negative predictive value here. Reasonable negative predictive value, though 4 times out of 100 I'd be wrong. Okay, so it's still a little bit wide, but not terribly. So this is a pretty good result here. Okay, this is what we're really wanting to look at here anyway. How good is this at ruling out the disease? Fine. Now, are these results of clinical importance? Do you think the hospital manager that you're going to report back would be impressed with this?
Yeah.
I think, wow, we might be able to save some money, save some complications, make it easier for people. Now, but you would never make such a decision based on one study. Okay, you'd want to see that this is repeated and that you have a good, reasonable chance of doing that. So what would you recommend? Would you recommend that you use it?
Recommend to look at more literature and see.
Yeah, yeah, okay. All right, so now you convinced your hospital director and they put it in your hospital. And now we have a patient. So someone read this scenario here and you tell me if you think you can rule out CAD in this patient based on the study results. So yeah, someone read the scenario and let's think about it. Anybody? Go ahead.
In your hospital, you see a diabetic 56-year-old man with hypertension, with example described as a personal testing lasting 5 minutes after rest. He has had 5 episodes of this pain over the past few weeks. An exercise stress test is positive, and the primary care physician refers him for coronary angio. You decide that you would like to use the CCTA to rule out coronary artery disease in this patient. Citing the very high negative predictive value of 99% here in this study, you reason that the CT angio is negative. You could avoid the more invasive coronary artery catheterization.
Okay. So do you think you can rule out CAD, given this very high negative predictive value here, in this patient? What do you think? Do you feel comfortable?
No, because from the history, no.
Okay.
The exercise test is positive.
Yeah.
So,
But if you send him to this test and it's negative, what do you think? 99.
You'll be in from in
Still
the fold.
1%.
You'll be in the fold that.
What's that?
It'll be in the fold that we will.
Well, it goes beyond that, actually. It goes beyond, but you're thinking right. I don't know about this. You're feeling like something doesn't seem right. What's not right? That's it. What's his pretest probability?
Depends on the sensitivity of the stress.
Well, no, forget about the sensitivity. What's this patient's?
He has symptoms, so he has a positive stress test, so he has
Yeah.
a high pretest probability.
Yeah. Very high pretest probability, above 90%. I mean, he has a positive stress test. That in and of itself pushed it way up, probably 99%. So now, the pretest probability is that. Let's see what happens. I think I have this here. What did I do with my clicker? Look what happens here. Okay, so here are the results of this study. What was the pretest probability in this study? Remember, it was low, 13 or 14%. So the prevalence was 13%, the sensitivity was 94, specificity was 82, the positive predictive value was 46, the negative predictive value was 99. That's from all of this, right? Now, what about our patient? Let's run the numbers. So what would you, let's see if we sent this man to the CT, and suppose it came back negative. Suppose it came back negative. Could we trust that negative test? So how do you start doing this? You fill in this with 1,000. Put 1,000 here. Then what do you do? How can you start solving using these three numbers: prevalence, sensitivity, specificity?
Sensitivity.
Well, the first thing, you put what, 94 here?
94%.
Well, not quite. Not quite. What's the what is this divided by the total? This by the total.
Prevalence.
The prevalence. So what percent of people have the disease? 900. So you put 900 people here and 100 here. Okay, so let's say it's 900 and 100. I'd even put higher, but given that scenario. Okay, so 900. Now how do you get these numbers? Multiply 90. 94% of 900 is 846. The sensitivity, if you take 846 divided by 900, you get 94. And then subtract, and you get 54 there. Then how about 100? What goes here? 83 and 17. Add them up. Now let's get the positive predicted value. 846 over 863. Positive predicted value is 98%. Very good. If you sent this guy to the CT scan and it came back positive, what could you tell him? You have heart disease. It's positive. You need to go for the cardiac cath. What if it were negative? 61%. Negative predictive value. What's 1 minus negative predictive value? 39. What percent of people like this who would have a negative test still have disease? 39%. Could you trust it? Do you see? So the lesson learned is never take the positive and negative predictive value from a paper and say, this is what it is in my patient. Killish, don't do it. Never. But the problem is, a lot of people reading the papers, they think that's what it is. That's the negative predictive value, but it's not. You've got to, now, can you take and use the sensitivity and specificity? Yes, you can do that as long as your patient could get into this study, is eligible for this study, which he is, okay? He could get into the study, you could use the sensitivity and specificity. Okay, so you have to recalculate the positive and negative predictive value for this patient using the sensitivity and specificity of the study.
So what we did, we applied the sensitivity specificity of the study on our patients.
Yes. Yeah,
Did this change the predictive value?
well, the pretest probability is what changed. The pretest probability of 90 compared to 13 is what really changed the positive and negative predictive value.
So we put the prevalence.
We use the sensitivity and specificity from the study,
Okay.
and then you put it in your patient. You use your patient's pretest probability, the sensitivity and specificity from the study, and then you can get the positive and negative predictive values for your patient.
Based on what?
Based on whether your patient could be a candidate for this study. Your patient is being referred for a cath. So some people had stress tests already, some people didn't have stress tests, some people. So this patient, in this scenario, is eligible to get in this study. So you could say, if he's eligible to get in this study, I will apply the sensitivity and specificity from this paper to my patient. It may be a little bit off, but still, I'll just use that, plug in my pretest probability into the equation from my patient's pretest probability. See, the pretest probability here was what in the paper? 13%. What's the pretest probability in my patient? 90%. So see the difference here, if you go back here, see here the pretest probability is 14%. Look at the positive predictive value, 46. The negative predictive value was 99. That's from the paper. But if you change this one and you make this one high, when the sensitivity and specificity are not that very high, it will change the positive and negative predictive values by a lot. Okay? And look what happened. Remember, the positive predictive value was 48 over there, now it's 98. The negative predictive value was 99 over there, and here it's 61. Do you see? So the pretest probability is what's really important. Let's suppose you did send this man, who you're sure he has heart disease, and you send it to the test, and the test is negative. That is a surprise. All the evidence is he has it, and now you want one test to tell you he doesn't? You better make sure the test has sufficient what? Sensitivity or specificity? Sensitivity. And in this case, is the sensitivity high enough to rule out? Do you see? Did I say something wrong?
No, everybody's saying something.
Do you see? Is the sensitivity high enough to rule out now? How many of you would have said sensitivity of 94 is mumtaz? It's very good. But it's not good enough in this case. Remember when I first started that lecture, I said, do not trust the sensitivity and specificity. Don't say, oh, this is really good, I can always rule out. No. You have to look at the pretest probability, the sensitivity, and the specificity all together, and you use these here. So in this particular case, because you're starting so high, you need a sensitivity probably of 99.5% in order to trust the negative test. With this pretest, because if you want to rule out, you want to be close to 0. If you go from 90 all the way to 0, you need a very sensitive test to trust it. Does that make sense? Okay. I hope I convinced you.
Yeah.
All right, let's see what else. Now, yeah, so using the sensitivity and specificity, if you go to this medcalc.com, plug in 90, 94, and 83, and some of you may have already done it. It comes out, right? It's very easy. You don't have to do all these calculations. You don't have to do all the calculations. Now, let's quickly look to finish. What time are we supposed to finish?
No.
12:30, huh? Okay. We already looked at this. in the lecture. Can I take 3 or 4 minutes and talk about these confidence intervals? Because I want to give a few more examples. Where's the cap? Here. Let's go back to the RCT. Remember clopidogrel in the prevention of stroke within the first 90 days? So it was 0.7, right? What was the confidence interval? Do you remember? 0.57 to 0.86 or something like that. Let's just say that's what it was. So when you're looking at this, you have to look at a number of things. You look at the magnitude of the benefit. 30% relative risk reduction. Is that a strong benefit, relatively speaking? 30% relative risk reduction, big relative risk reduction. Next thing you look at is the absolute risk reductions related to the number needed to treat. So you look at the number needed to treat and you say it was 25, right? So you say from a relative risk standpoint, there's a big relative risk reduction. The 25, what does the 25 mean? I need to treat 25 people with clopidogrel for 90 days to prevent 1 stroke. And I look at that and I say, is that a pretty good deal? Is that a good deal? I need to spend money and risk of bleeding and all the different things. Well, outcome is stroke. So that's a big outcome. And 25, clopidogrel is not that expensive. It has some risk of minor bleeding, but the major bleeding there wasn't. Remember? So you look at the relative risk reduction, mumtaz. The number needed to treat, really good. Then, so you say, look, the magnitude is of good magnitude, a big benefit, but how much confidence do I have in it? Remember, this is the 30%. But now, what would I do? What would you do if the truth were here? What would you recommend? Let's say that based on this number, you would recommend giving clopidogrel. What do you think about this number? Remember what I said, I am 95% confident of what? That the true relative risk is somewhere in between here. I'm not 100% sure, but I'm 95% sure that it's somewhere in between here, right? What would you do at the lower end? Would you treat? Yes. What would you do at the upper end? Would you treat? Yeah, probably. Let's say yes plus and yes. But they're both saying yes. Okay, because still a 14% relative risk reduction in stroke, and you could look at the number needed to treat for that and everything if you wanted. But look, you're having the same decision at both ends. So you say, well, are you confident in this number? I'm pretty confident. Now let's say it went to 0.4 to 0.99. What would you say then? At this end, would you do it? At this end? Yes. At this end, would you do it? No. So now it's different at both ends. So now I have less confidence. Now, is this statistically significant? This one up here.
Yes.
How can you tell? The range does not include the value of no association, which for a relative risk is 1. It's not included here. So I know this is statistically significant. Let's say significant. Is this one significant?
Yes.
It's significant. In this case, the p-value is probably 0.049. It's just significant because it's just about to 1. You know what the drug reps will do? You need to use clopidogrel. The result study was significant, right? And too many people are just looking at the p-value. Is it significant or not significant? right? Now you have the tools to have a lot more information when you see this. Because what would you tell the patient if this were true? Would you give it or would you not give it? Well, think a little bit. What's the more likely thing, that it works or does not work? Is it more likely that it works or more likely that it does not work? More likely. Look at all these numbers. It could be really, really big. The truth could be here. It could be 0.5. It could be 0.6, 0.7, 0.8, 0.9. And then there's some possibility that it doesn't work. So what would you tell your patient?
Depends on side effects.
Well, let's say the side effects are acceptable and everything. What could you actually tell your patient?
That
The benefits
if we use this
outweigh
drug,
the risk.
Yeah.
if it doesn't benefit you, it won't harm you.
Okay, yeah, so we're not seeing anything way up here that there's any evidence that it harms, and we looked at the bleeding risks and we looked at all these other side effects. So we think it probably does work, but there still is a possibility that it doesn't. But look, the side effect profile is such that we think we should try it because this bad outcome of stroke seems to probably be reduced. And the other thing to remember is this one is still your best estimate. This is the best estimate out of all of these. So you say, oh, okay, I would use it. Now what would you do if it went like this, 0.4 to 1.02? What would you do in that case? It's not significant. Throw the paper out. Don't use it, right? I'm trying to lead you down the wrong way. What's the problem here? If you see this configuration, 0.7, 0.4 to 1.02, it's no longer significant, but is this really any different from this? Honestly? Are these two papers any different? Not different at all. Oops, sorry. Do you see? This is not significant, this is significant, but really, it's the same thing. Look, the p-value is just an arbitrary cutoff. If it's a little above or a little below, I would still say, well, what happened here, those investigators were crying at night, saying, why didn't we get 100 more people in the study? Because what's the problem with this study? If you see this, the sample size is too small. Do you see the problem? I look at this, I say, it probably works, but the sample size was too small. Do you see what I mean? But it's not statistically significant, so I have even less confidence. I'm not as confident in this, but if this is all I had, well, if this is all you had, would you give it or would you not give it? I would give it. Do you see? So don't depend on the p-value. You've got to look at how big is the benefit, and there seems to be a big benefit here, and the number needed to treat is small. Does that make sense? And then what if you saw this, 0.7, and would you consider this wide? Yes, because the inference here is do it, and the inference up there is it doesn't do anything. Don't do it. What if it were 0.1 to 7.9? Yeah, what do you say about this if you saw this paper? It's not significant.
Throw it away.
Ahsan, that's it. Is this wide? It's not wide. It's wide. That's what I always do that one. You know, I say wide. This is wide. You don't. This is so wide. You just throw that paper out. You can't trust anything